And I'm really excited to welcome you all today to this first session on looking at COVID-19 response and how it plays out in Indian country. This workshop is a collaboration between the Intertribal Council of Arizona and Seven Directions. And we're really excited today because we're able to hear from some incredible folks about their COVID-19 response work. This is the first session, like I mentioned, looking at tribal self-governance specifically during the COVID-19 pandemic. So I want to go ahead and give you an overview of what our time looks like today before we get started with our panelists. The session is scheduled for an hour and a half to allow for ample time for questions and discussion with our panelists. However, if you do have to leave at the hour, we totally understand that everyone's really busy and there's a lot going on. We are recording the session and it will be available on the Seven Directions website at indigenousphi.org. And I believe a link will also be made on the ITCA website as well. Before we get started, we do want to kind of get to know folks who are joining us today. If you've joined us previously for our Gathering Ground sessions, we like to kind of just get a sense of who's on the line or who's joining the Zoom meeting. If you could insert your responses into the chat, we would really appreciate it. And that way other folks can see, you know, who you are, where you're coming from, and what are some of the things that you're interested in focusing on today during the session. And before we get started, just a quick reminder to please keep your mic on mute during the presentations and to submit any questions through the chat. We have a little over 30 folks on the Zoom call today, so it just helps to kind of maintain the flow of the discussion. If you would like to go ahead and ask some of the questions yourself, we can try to make that available to you, but I'm happy to read any questions that you might have also to sort of just keep moving the conversation forward. Another reminder, today our objectives are to examine memorandum of understanding and agreement and other types of documents that are needed to work with universities, county partners, and also state departments. And so we'll hear from our panelists about how to navigate that. We also want to discuss a little bit about public health authority and what that looks like for tribal nations and tribal epidemiology centers. And then we want to highlight the experiences and best practices in conducting infectious disease response work by and with tribal nations and tribal epidemiology centers. And so today we're really grateful that Chairwoman Lee Gatewood from the White Mountain Apache Tribe was able to join us, and also Mr. Adrian Dominguez from the Urban Indian Health Institute, which is located in Seattle, Washington. Chairwoman Gatewood's family is from Cibecue in Arizona. She's the youngest of 11 siblings, and she's the first ever female elected to the highest office for White Mountain Apache Tribe. She's a graduate of Shola High School and Northern Arizona University and is married to Marty Gatewood, and they have 3 children. She enjoys horseback riding and the outdoors. And thank you so much, Chairwoman Lee Gatewood, for joining us this morning. We really appreciate it. Adrian received his Master's of Science in Epidemiology and Biostatistics from the School of Public Health at the University of California in Los Angeles in 1988. He was awarded the Harvard University Health Professionals Fellowship and attended Harvard University to study neurology and public health. He has over 23 years of experience working as an epidemiologist, and his work includes pediatric lead poisoning and low-income areas, HIV/AIDS, maternal and child health, diabetes, breast and cervical cancer, social determinants of health and health equity, community health assessments, and evaluations. And so thank you, Adrian, for taking the time. I know you're super busy working on COVID-19 among many other issues facing urban Indian populations around the country. Welcome to you both, and thank you for being here. And now I'd like to go ahead and turn it over to Chairwoman Lee Gatewood to share about her community's response and what public health authority looks like for her and her community, and the partnerships that were critical to the response work that her community is engaged in.
Good morning, everybody. Welcome to this I consider it any time that we could come together and meet to discuss how we can improve and help one another is a good get together. And the fact that we are working towards helping one another in our response, our MOUs, MOAs, what have you, is a sign that we are truly linking arms and just having a better course to the future and for our children and generations yet to come. But here is my slide presentation that I would like to share with you. And it's an update on COVID-19 response from the White Mountain Apache tribe. And there's some of our tribal kids linking arm in arm. Next slide, please. Those of you that don't know where White Mountain Apache tribe is, we're in Arizona. We're about 3.5 hours away from Phoenix. We are in a four season location. We have all the seasons. We have a ski resort here, and we still have snow. So next slide, please. That's a part of our area in town, the river. And April 1st was the first COVID case on the Fort Apache Indian Reservation. It was a day of our general election as well. It really affected how many people came out to vote. I couldn't believe the reaction. Next slide, please. We immediately had a growth of expanded testing. We immediately went into contact tracing, wraparound services with Tribal Health Division, Indian Health Service, and Johns Hopkins University as partners. And that's a photo there of everybody just coming together. Next slide, please. We've been doing care packages from day one, and this is just a photo to show you those care packages. Next slide, please. And, you know, as I described earlier, we just have been doing nonstop food and masks delivery made by our own tribal members for those in quarantine. And from my office, we are still doing semi-truck food deliveries in partnership with Shamrock and Farmers to Families program. To date, we've had 19 semi-trucks come and deliver over 22,000 cases of food, and we have deliveries once a week that has about all the food groups you could think of. And so that really helps our community. Next slide, please. We have water distributions, and just there's a photo of a young baby there drinking water. Water is so precious to all of us. It's life. And during COVID, we're in COVID right now, but there were times where we did lockdowns. And during those lockdowns, we had a water shortage in terms of water to the communities. Our wells just stopped supplying water. So as you know, with COVID, you need to wash your hands, be hygienic. And we had asked everyone to stay in their homes during this lockdown. And when you don't have water in the community, you have no choice but to just undo your lockdown so that the people can go to your supermarkets and get the needed supply. And that was really, really challenging. That happened to us, I believe, on 2 occasions. So next slide, please. We've prioritized elders. They are first in line to get the COVID vaccine, first in line to get all of the items that we need. And then we have a program with Johns Hopkins University and our local partners of housing and our local lumber company building shelters for our high-risk elders, so that if someone in the household has to quarantine, the elder can go out into the shelter which is basically a detached bedroom, and it has everything in there for them. And they can stay there during the time that the household is on quarantine, just to help further protect them from the dangers of COVID-19 while waiting for the vaccine. And just elders in general are very vulnerable. And with the population of 18,000 here at the tribe, 80 years and older we just have 200 of them left. And during COVID, we've had 49 deaths. And of that, I believe 9 or 10 are in that 80 and over age category. So if you subtract that from the 200, we are now at 190 or a little bit under that for the 80 and over age group. So next slide, please. We've had baby supplies for small children. That's been a very big assistance for our babies, and doing our best to help protect them as well. Next slide, please. This is specific health communications, how we're trying to help improve our communications to our tribal members. And this is just to let you know of some communication pieces that we have to explain to our tribal elders and tribal kids. Most of our people are visual. They have to see something to say, oh, okay. And this communication piece started off on what it is, what are the symptoms, how does it spread, and just doing it as basic as we could. And that really helped our population out there to understand and see what is needed. And as you can see, there's a multi-generational photo right there. And in our native population, in our homes, we have multi-generational homes. I'm sure all of Indian country has that, and that plays a big role in how COVID-19 spreads, and that's also a challenge there. Next slide, please. We had reservation border lockdown and curfews. We've had mask enforcement. We had to close our casino. That was pretty challenging because our casino is the main anchor of our revenue generation for our tribe. We prohibited alcohol through December 2020, but since then our tribal leadership have continued the ban of alcohol on our reservation. And we have information from Johns Hopkins in real-time data that can tell us how we're doing in the trend of our positives and what it looks like, how we flatten the curve, what's next, expectations. And just to comment, that's me. That's a mask that I helped promote. I created the design, and on the bottom jawline is an Apache word, Atagotzitsan, and what that means is take heed, take care of yourself, be watchful over yourself. And during a time when we had resistance to people wanting to wear a mask, I thought to myself, how could we get people to, in a sense, want to wear a mask? And I just came up with that. And I honestly didn't think anyone would like it or respond. I was thinking it'll probably just fail, but I went ahead and tried it. And boy, it really took off with such acceptance, and such people were very prideful. They were like, wow, I'm wearing this mask and I'm going to wear it wherever I go. And that was such a positive response. And then pretty soon everyone was like, can I have a mask? Can I have a mask? And I had to do a lot of fundraising to help every order that I've had to do. And to date, we've passed out about 13,000 masks to elderly, to small children, and we're still doing that campaign. And that really seemed to draw people together. And it was a public health advocacy without the person thinking about it, because I saw one in a grocery store where an elderly was wearing it, and this lady who was not native said, wow, you have a beautiful mask. What does that say, that word? And she just said, oh, it means to protect yourself. And this is our great seal. And I have to wear this mask. I mean, without her thinking about it, she was already doing public health education to someone who was asking about this mask. So I thought it was a really great change for the people. Next slide, please. And then we were also featured in the New York Times about how contact tracing is saving lives. We really, really focused on contact tracing. We're still doing it to this day. And as the coronavirus spread on the Fort Apache Reservation in Arizona, medical teams sought out residents who might have been exposed. The effort has paid off in unexpected ways. So the contact tracing, what that did was we really went out to the communities to identify who was exposed, came together on the quarantine efforts, and the high risk ones, our medical teams just started checking on them daily, their oxygen level, what have you, to the minute it changed, we got to get you to the hospital. And that really, really has helped in our response to COVID-19. Next slide, please. And Apaches have been infected at more than 10 times the rate of people in the state as a whole, yet their death rate from COVID-19 is far lower, just 1.3% as compared to 2.1% in Arizona. Epidemiologists have a hopeful theory about what led this starting result: intensive contact tracing on the reservation, likely enabled teams that included doctors to find and treat gravely ill people before it was too late to save them. Next slide, please. We've had vaccine blitzes accompanied by food support, and that food distribution, the boxes that my office distributes, we try to set it up next to vaccine blitzes so that people are drawn in, and then we kind of we encourage them to go get the vaccine. And we do have some vaccine hesitancy, but we're working through that. Next slide, please. Again, here's our example of our food boxes that we do. This is not the food boxes that we distribute. Those are all boxed up and taped, but this is from the community, what we put together for our people. And elders come as a priority for this. Next slide, please. We've had the vaccine blitzes in various areas of our community, and this is just a photo of one of those. Next slide, please. No weather is too tough. Persistence is our mantra. We've had snow, rain, what have you. We're still out there because COVID doesn't take a day off. And one nurse said, COVID doesn't take a day off, why should I? And she's just been very instrumental, showing up every day, long hours to help our people. And that really is a testament to the healthcare workers and their commitment to help save lives. Next slide, please. Again, ongoing data-informed decision-making by our tribal council, IHS and Hopkins continue to provide real-time data. Next slide, please. This is a chart, a new COVID cases by day, and it starts from April 1st when we got our first COVID case, all the way to February 19. As you can see, it kind of goes up and then down and up again. Right now, we are at 29 positive cases. Just 2 days ago, we were down to 18. What I see happen is when the numbers drop all the way down, we had a very significant snowstorm, 2 snowstorms that really probably brought about 3 to 4 feet of snow here. That really helped. Mother Nature helped in that people just stayed home and they didn't go anywhere. So that really helped the numbers drop. But as the sun is out and the weather's good, people are starting to, and the vaccine is here, people are like, oh, we should have a birthday party for Timmy. And then they're starting to invite grandma, and we're like, don't do that. So I'm hoping that people refrain from having anyone outside their household come together as a bigger group, because that's where the spread is. So next slide, please. Then we get weekly data summaries provided to Tribal Council by Johns Hopkins University. Their epidemiologists give us these reports. And as you can see, we have age distribution, male and female. There's more females that seem to get COVID than there are males. And then the percentage by age group. And the 25 to 34-year-olds are the highest, as you can see from the graph. And then 35 to 44, and then 15 to 24, and then 55 to 64. Next slide, please. Vaccination rates. This is a White River Service Unit, our Indian Health Service, percent initiating and completing vaccination by age group. So as you can see, earlier I said we're focusing on our elders. So we're really trying to get our elders to get vaccinated. And some of them, bless their hearts, are a little bit hesitant. And we're doing what we can to have other elders who have gotten the vaccine to be on the radio, to be on social media, to have a piece on our newspaper to say, I got the vaccine and I'm doing okay. And then as a tribal leader, I was the first of the leaders to get the vaccine when the vaccine came to the reservation. And I didn't expect to be asked. I just arrived the day the vaccine came to the hospital, and I wanted to thank the Creator for bringing the medicine to our people. And at that time, the doctors and those there were like, Chairwoman, would you please consider getting the vaccine shot today? We believe that if you do it, people will generally accept this vaccine. That was quite a shock, because I'll be honest, after everything that I had been reading, hearing, I was like, I don't know if I want this vaccine. That was the time where I said, when do you want me to come back? And they said 3 o'clock. So I went home, I said a prayer with my children, and then my children wanted to come with me. And so they came and watched Mom get their shot. And, you know, I was grateful for it. And I felt I had a good feeling. And then after that, I started talking about it. And the more people saw that nothing happened to our chairwoman, even though she got her shot, because of the misconception and the misunderstanding, they were like, oh, well, if she can get it, then I'm going to go get it. So if it's going to help someone else, and then it would be not good if I'm telling people to get something and I'm not doing it myself. That's not a good example of leadership. So having gotten the vaccine and doing that for the purposes of public health, I'm glad that I did that, because that seemed to help ease the members' anxiety. So next slide, please. Mental health promotion is our next thing that we are engaging in, and also still continuing on the other facets of what we're doing. Next slide, please. Mental health needs related to acute distress due to severe losses and consequences from COVID-19, grief, anxiety, depression, PTSD, historical trauma, suicide, domestic intimate partner violence, increased or riskier substance abuse. During the times of these lockdowns and shelter in place, our police department told us crime, or not crime, but domestic violence is increasing. People are getting mad at each other because they're just having to stay together and they don't have anywhere to go. So that was a challenge. Children not being able to associate with their friends because school is no longer available, but online is. Our tribe, our internet is not the greatest, and we're still working on improving our broadband. So when college kids came home, we're in lockdown, they can't go anywhere. They have exams or papers due. They have no internet, but they're told they can't go anywhere. I would get phone calls or email, Chairwoman, I have this assignment due today, but we're on lockdown. I don't have internet at my house. I need to go somewhere with Wi-Fi. And pretty soon, more and more were doing that. So that was a challenge, and it added to the stress, it added to the anxiety, and having a multi-generational home where mom and dad are trying to keep the family fed, grandma's trying to watch out for her health, the kids are trying to do online school. All of that adds to your anxiety, and that's where you get your depression and post-traumatic stress issues, and then suicide. Unfortunately, we did have some suicides, and we lost our medicine man to COVID. That really affected a lot of people because he helped thousands and thousands of people through prayer and ceremony. And when he died from COVID-19, it sent a shockwave throughout the community. Next slide, please. Psychological support for special groups, children and parents. We have Children's Storybook promoting hope and resilience with parent resources, coloring pages, and children's activities. Wherever I went to the store, if I saw a little child, I tried to be encouraging. I'm chairwoman, but also I see myself as also a mother. And when I see children, I talk to them as how I would talk to my own children. And some of them literally were honest. They're like, are we ever gonna see our friends again? They were really worried. And I would be like, yes, you are. And you need to just remember that right now we're trying to keep the virus away, and you need to help, and just being encouraging to them. And you could actually see the worry in some of those kids' eyes. So next slide, please. It's some more about the well-being and your relatives' well-being, some informational sources that we give out to the community. Next slide, please. And then our ongoing work with Johns Hopkins University and other partners. We're doing follow-up on our Pfizer vaccine trial. We do have Pfizer and Moderna at our White River Service Unit, but Pfizer was the trial that the council approved before, back in, I believe, early May or June, for people to enroll in the trial. We're doing antibody testing, continued household surveillance and long-term follow-up, brief interventions to promote rapid testing after symptoms, Safe Schools project. 2 of our schools on the reservation have gone back to in-person learning. I am a school board president for Theodore Roosevelt School, which is the oldest school on our reservation, which is a BIE school, which is tribally run. And we've gone back to school, and we've had to do our safety plans and all of that. Indian Health Service was a partner, Johns Hopkins and EOC, all the partners. Before we even said to the council we're ready to go back, we made sure our safety measures and how we're going to do this was in place. And then home health interventions, home visiting, communication campaign to promote vaccine in other areas. Next slide, please. I think that's still the same one. Is that the end?
Yeah, that's the last slide.
Okay, but in terms of the MOAs and the collaborative agreement with Johns Hopkins, we go back decades. We go back to 40 years of a relationship with White Mountain Apache Tribe. And they came on board at a time when White Mountain Apache Tribe was experiencing a lot of infant death from dehydration. So we just didn't bring them in. My former boss, my late boss, Chairman Lupi, who I was his executive assistant for 12 years, brought them in, but he told them, you can't just come in and leave. And we had in our clause that, in order to come onto the reservation, to have this MOA, MOU, what have you, you need to take the time to learn about our culture and our people. Don't just have that helicopter approach of coming and leaving and never coming back. So Johns Hopkins has been instrumental in maintaining that approach. They have an office on our reservation and tribal members that work there, and then also non-tribal members. But it's very critical to have the MOAs and MOUs, especially when it comes to research, because you don't just want people to come in and start doing their research without some precautions, some things that we need them to abide by, because you need to maintain that trust for your people and you need to protect them. But you also want to help save them so that they're not subject to illnesses that could wipe your people out, kind of like the challenge COVID-19 has brought to us. And COVID-19 was a public health emergency. And because it was a public health emergency, that was a time where tribal council, other partners were like, we really don't have much time to go through the red tape of what normally happens. So here's what we're going to do. So that's where the partners came together to try to work things through as we went along throughout the emergency. We were in a response phase at the beginning, and now we're at a management phase after we've had some time to learn about how COVID is, how it affects our people, and what we can do to help minimize what it's done. And we've had a big plus with monoclonal IV treatments to our people, and people that normally who would be considered high risk if they got COVID. We give them that treatment and they go home, and they seem to recover a lot faster, and the effects of COVID has been minimal with them. And the transition between teams, Johns Hopkins, IHS, and the tribe with contact tracing, having that ability to transition has helped in the MOAs and MOUs, but we streamline that information, and we protect that information as long as we are making sure that the people are being served. And we've also had volunteers and donors who have contributed to helping to mitigate COVID-19 on our reservation. And the strength there amongst all the partners is what really has helped. And then the agreement with White River Service Unit and the Tribe, Division of Health, EOC. We work together on other campaigns, Rocky Mountain Spotted Fever, diabetes. And then we come together in that common goal. So, it is so important to work together, especially for public health, to minimize the impact to your people. And having the discussions beforehand, establishing that relationship based on mutual respect, friendship, longevity. You don't want to just have a partner that's just there for a moment's time and then they leave and you never see them again. You want to develop that relationship over time. They get to know your people, and then they invest in that. You invest in your people so that the challenges of disease and illnesses can be minimized, and you're working together through it all. And especially during this time of a pandemic, boy, it really tested our faith. The people just really had to adapt, and especially the children, and especially our cultural ways. We went from you could do that to you can't do that anymore, and then having to explain. And I'm very, very proud of all the partners that have been working together, and the tribal council analyzing these MOAs, MOUs, and asking the questions and making sure that people will get the help, but they're not taken advantage of, and that the research, we own the research, and we own the work that is done. And we're very careful on who comes in, because all that time you have to maintain that trust. So right now we are moving forward, slowly reopening, but again, also being cautious. But COVID-19 on the financial side has really affected our businesses here on the reservation. Like I said, we had to close the casino, we had to close the enterprises, and having to explain to the people that who felt like you should stay closed, and telling them, we have to find a way to pay our bills. We have to find a way to pay you your take-home pay so that you can feed your families. And here's how we're going to do it. And as long as you tell them the why behind what you're doing, and being transparent, and holding on to their trust, and doing what you can to minimize the impact, it has really been very, very helpful. And we always depend on the Creator. We've had prayer day, and we've had help through the Creator with that as well. We never forget our faith and our prayer and our reliance on the Creator. Those are the core values and trust that our ancestors carried on through their own trials, and it's in our DNA. And as long as Indigenous people stay together and hold on to that rope, if you will, you know how a rope is interwoven, and the tighter the link, the stronger the rope, and it cannot be broken. We have to stay on that trend in order to help mitigate what disease and illnesses bring to our doorstep. And I'm very happy to have been to be a presenter today. Thank you.
Thank you so much, Chairwoman. We really appreciate your presentation and everything that you shared, and we'll get a chance to talk a little bit more about some of those agreements that you all have put in place, and also some more details about your COVID response in a little bit. Now I'd like to go ahead and turn it over to Adrian, who will share about the Urban Indian Health Institute's role in response work and their partnerships that they've been putting in place in order to do the work that they're doing with COVID-19. Adrian?
Yeah, I'm going to share my screen. Are you able to see that?
Yeah, we are. Thank you.
Okay. Is it advancing?
Yes, it is.
Okay, great. So my name is Adrian Dominguez. I am the Chief Information Officer for Seattle Indian Health Board, Urban Indian Health Institute, and we're based out of Seattle. I want to thank you guys for inviting me to participate in this panel discussion. I'm going to talk a little bit about our work that we've been doing on COVID-19 and some of actually the challenges that we've had in accessing the data from a national perspective, and also from certain states. I'll show you some of the work that we've done, and I'll talk to you a little bit about the work as a tribal epidemiology center, and how that impacts the overall data that's being shared by CDC and by state departments of health. So the first thing I just want to talk to you about is who the Urban Indian Health Institute. We're a tribal epidemiology center. There's 12 of them in the United States. Unlike the other 11 are regional tribal epidemiology centers. We are a national tribal epidemiology center focusing our attention on urban Indian organizations, urban Indian populations throughout the United States. And this is a map of all the specific urban areas that we work with. There are urban programs in these specific cities, metro areas. In addition to working with these programs, we also work with state and local health jurisdictions where these programs are located. There's approximately, I think it's just over 70 urban programs that we work with, and approximately like 30 state health departments. And so with regards to COVID-19, we've been accessing state level COVID-19 data, and then also accessing the data from CDC. Just some of the work that we've been doing is what we did at Urban Indian Health Institute is we did recognize that there was limited resources available out there that are specifically for American Indian, Alaska Native Indigenous populations. There wasn't a whole lot of culturally appropriate, attuned educational material. And so our organization, what we decided to do was really focus initially on the pandemic, was to provide data resources specific on COVID-19 and how it was impacting American Indian, Alaska Native populations. If you go onto our websites, there's more than 30 plus resources specific on COVID-19, also on the vaccinations and how it relates to Indigenous populations. We've done a weekly national survey of COVID-19 and the impact that it has on the UIHOs. And what we do is we assess the screening and the testings that are happening at those urban Indian health programs. We assess and identify the different demographic and high-risk populations within those urban Indian health programs, and how and what the positivity rates are for those populations. We also look at the impact that COVID-19 is having on the staff of the urban Indian health programs, assessing the protective equipment supplies that they have, and the testing supplies that are available to them. As I said earlier, we obtain the national COVID-19 surveillance data from the CDC. We get that on a weekly basis, and I'll show you some of the work that we've done as a result of receiving that information. And I will say that that particular data set has been a real challenge. I think part of our responsibility to begin with the CDC was to question the completeness of that data and the lack of data with regards to American Indian, Alaska Native population. It was so incomplete that it was hard to initially do any type of assessment on outcomes for Indigenous populations. And what we were really relying was basically what states or CDC were providing, which in our mind from our Tribal Epidemiology Center, there was a lot of questions that we have, and there were certainly gaps in that information and the analysis that were being conducted. The other thing is we do some state reporting for COVID-19, depending on which states we have a data sharing agreement with. We do actually also get specific COVID-19 data from individual states, and we were able to compare the data that the states are collecting compared to the data that is being sent to the CDC. And I'll show you a report that we recently published grading the each state on how well they're collecting data and how well they're collecting racial data and specifically American Indian, Alaska Native data. We also did what we found was really important, that there wasn't a whole lot of information about Indigenous populations, knowledge, attitudes, and belief with regards to COVID-19. So we did a national survey. We had I think it was over 1,300 people participate in that survey, and I'll show you a little bit about that. And it was really a information to help us assess what were the hesitancies of being vaccinated in American Indian, Alaska Native populations, and what specifically did they need in order to feel comfortable about getting vaccinated. So I want to start off by this, is initially when we got this information, when we started receiving information on COVID-19 back in, I would say in March, one of the things that we found, and the other tribal epidemiology centers also were having the same questions as we did, and that was that we knew in our communities that our populations were being impacted at a higher rate than the general population, than white non-Hispanics. However, very early on, states were not collecting that data on race with regards to COVID. And no one was really challenging them. And there was just data that was being put out. And in a sense, it was just like, this is the overall infection rate for the population. And it wasn't until later on, I'd say like starting like in April and in May, where colleagues of mine, myself, other tribal epidemiology centers that are working specifically with indigenous populations, colleagues that were working with African-American population, the Latino population, we're identifying that there's high rates of impact, high rates of infection in these populations. However, the federal government and state governments weren't really sharing that information, and in some instances weren't even collecting that information. And so it was hard for people to see specifically the impact that it was having on our populations. And I don't think many states were even up to wanting to hear that they needed to do something about this. And as we started to move forward as the pandemic progressed, we started actually looking at the data that states were capturing. And in this graph here shows you specifically the racial data that was being collected by states and or that was not being collected. And so, for instance, if you look at Oklahoma, Oklahoma very early on, they were not collecting any data on race. And we know for a fact, Oklahoma is one of those states, is one state that has a high proportion of American Indian Alaskan natives living in that state. But if we don't have that data from them with regards to race, then it's very difficult for us to assess the impact that COVID is having on the population. And as you can see, there's some states that did fairly well, and there's other states that did really poorly in this. And it was just really difficult for us to even put together a report on a state level or even on a national level. Here is hold on a second, let me do this. So here is a trend analysis showing, and this goes only to October, and we have some data going all actually way to January of 2021. But this was showing us the data that was being collected that had race in their data sets. And what we heard a lot from CDC and what we heard a lot from various states is that, oh, we're going to start collecting this data, and we're doing a better job at collecting this data. And yes, we are improving. And what we were showing, our experience was something completely different. And I'll show you, like in the state of Washington, State Health Department kept on saying, we're doing a better job, we're doing a better job. And in reality, they weren't doing a better job. And so it was important for us to show that although you say you're going to collect this information, you're actually not collecting this information. And you'll see, and this actually has gone down. If you go to, if I could show data from just January 2021, what we find is that overall, with the states that are collecting, with the states that collect the data on COVID-19, specifically on race, the completeness is less than 50%. So we still need a ways to go. States are not providing this information, and we are having conversations with federal agencies as well in how to improve this. And I'll show you one report that we just did to address this. This was just showing, this is why we wanted, it was really important to show that why we were wanting this information, because what we were seeing, like I said very early on, is that the impact of COVID-19 on American Indian Alaskan Natives was substantially higher than that of non-Hispanic whites in the United States. This is, again, just showing you the different impact, or the proportion of each age group in which American Indian Alaskan Natives were being impacted, and compared to non-Hispanic whites. And you see a greater proportion for each of these age groups American Indian Alaskan Natives are being impacted at a greater rate than compared to non-Hispanic whites, except for, you know, the 80 plus years, 70, 79, 80 plus years. But if you look at every other category, it's higher for American Indian Alaskan Natives. And again, I'm stressing the fact that this is data that we have, but there was over like 50% incompleteness with racial data. So we suspect that this was even higher than what it's showing here. This is just looking at the cumulative incidence for each different age group. And you see that for each age group, American Indian and Alaskan Natives are significantly higher than white non-Hispanics. And as a result of all of this, we also know that because of this, it was really important that Indigenous populations get vaccinated, and they should be identified as a priority group in receiving COVID-19 vaccinations. We did 2 publications, or we participated, I should say, in 2 publications. Several of the other tribal epidemiology centers also participated in this. And one was looking at the infection rates of American Indian Alaskan Natives on COVID-19. Now, we were only able to look at 23 states because the level of completeness was large enough so that we could assess those states, as opposed to some other states which there was not enough data, so they could not be in this this analysis. And so again, you see how this impacts the overall analyses and interpretation of data and any type of assessments that can be done with the data that is being received by the CDC. We also participated in another MMWR, looking at mortality of American Indian Alaskan Natives in the United States. But in this case, we could only use data from 14 states because, again, the level of completeness for those states was, they didn't have enough racial data for us to actually do any type of assessment. And so again, it shows the importance for us to have the data that's being received to be complete. We can't make generalizations on these 2 reports for the entire populations, but we can essentially say, based off the data that we have, this is what is happening. And so if you go on to these publications, you will see that the impact on American Indian Alaskan Natives was significantly and substantially higher for Indigenous populations compared to white non-Hispanics. Now, these are the 2 recent publications that we have that we produced. You go onto our website, you can download these, and it's really interesting information and data that that has been generated from here. Let me focus on the strengthening the vaccine efforts in Indian country. This is the survey that we did. Like I said, there was about 1,400 participants in this survey, and this was the entire United States. It was not specifically in urban areas. This was rural, tribal, and urban areas. So wherever the person lived, it didn't matter. If they completed the survey, they were in the analysis. And what this showed us, if you going into this data, was that there was a high level of hesitancy in American Indian Alaskan Native populations. It wasn't as high as we thought it was going to be. There were individuals, there was a good proportion of individuals that were willing to get vaccinated. However, they wanted to know more about the vaccines themselves. And those who were hesitant about being vaccinated had said that they would be interested in getting vaccinated. However, they wanted to wait to see the impact of the vaccine on the population. And just like the chairwoman said, what was interesting is they also wanted to see other people that they looked up to or they felt were of significance in their community, that if they did it, then they were willing to also receive the vaccine. there was also this difference in the level of trust in the information. So for instance, if CDC was providing information on vaccination, they were less of a trusted resource, as opposed to if information came from, say, a trusted organization, or a resource that specifically worked with indigenous populations in the US. The data in here also could be used to develop any type of educational material. We certainly have, there's some resources in here that could assist in identifying how to develop these resources, what would be important in these resources they can develop. So I recommend certainly going to our website and downloading this report. It has a lot of really, really good information. The second report, this data genocide of American Indian Alaskan Natives. So this was a result of us receiving the data from CDC. And like I said, we get this pretty much like on a weekly basis. And what we were trying to figure, this was prompted as a result of a frustration of the level of completeness of the data, and having to work with different state health departments, and then also working with the CDC. And some federal agencies, and there just didn't seem to be any willingness to address some of these problems in which the data, the level of completeness in which the data had been collected. And so what we decided to do is to assess each one of the states in the US, and this is what the report card looks like. So each state, for the most part, I think there was 3 states that didn't follow the same method because the data we had was not available, like Alaska is one of them. But for the most part, all of the states were given a grade based off of 4 different metrics. And then states like Alaska, I think there was 3 of them, were only based off of 3 metrics. And each one was, so the metrics that we're looking at is, we looked at each state health department's dashboard, and we wanted to see whether or not they had American Indian Alaskan Native information on that state dashboard. If they did not, then they received a letter of F, or 0%, because it was either yes or no. If they did have data on that dashboard on American Indian Alaskan Native, then they received 100%. And then we looked at the level of completeness of the data of racial information on that dashboard. And so each state determines or shows, how much data they has racial data. And basically it just follows a letter grade. So you could see, like for Alabama, only 49% of the data that they have on their dashboard has racial information on it. So they received an F. Whereas, like, if you saw, like, Arkansas had 82% of the data that they received, or that they show has racial information, so they have a B-. The other thing is, what was really interesting, and I think people just take this as they just assume that the data that is being collected at the state level is the data that is being submitted to CDC, and that is not the case. The data that the state collects is not necessarily this data that is submitted to CDC. The states have an option of how and what they send to the CDC. And so when we would look at the CDC data, we were comparing the number of cases that were reported on the state dashboard to the number that we saw on the CDC data set. And a lot of times there wasn't a 1-to-1 match. So for instance, in Alabama, only 62% of confirmed cases that were reported on the state's dashboard were being reported to CDC. And then of those confirmed cases, how many had the racial information, racial data, excuse me, on the data set that was sent to CDC. And so you'll see, like Alabama, only 62% of those confirmed cases, of the 62% confirmed cases that were sent to CDC, had racial information. So overall, Alabama gets an F grade in the data that is being collected and presented on COVID-19. And you can go onto our website and you can see each different state has their own letter grade. Now, let me stop sharing. So let me explain something on this. The reason we did this, and we're talking about data sharing agreements, and we're talking about these collaborative relationships that we have. I think it's really important that we, as an organization, as Indigenous people, that we are the ones that lead these efforts, and we are the ones that call out whether it's a state health department, a local health jurisdiction, CDC, federal agency, is that they're not doing a very good job. And I think that I will give you an example, specifically like in Washington State. I'm having a really difficult time working with the state because the state continues to say that they're doing a really good job in collecting data. However, when I present this data and I show them that they're not doing a really good job, they're like, okay, well, we're working at it. And to me, when you say you're working at it and you just had a year to do this and you're still not producing this, accurate information or enough information, then you're not doing a really good job. And that was part of the reason why we did this report card, was because we were just basically tired of waiting for the states to do something, waiting for CDC to do something. Because without this information, without it being accurate, without racial information, then it's really hard for us to do our jobs. It is really hard for us to assess the health and well-being of Indigenous people. It is difficult for us to assess the impact COVID-19 is having on Indigenous people. And so we've been just a real, we've literally have taken the lead in trying to address the data that is being collected. And I would say, we're not just stopping with COVID-19. We find this across the board with any type of data that we are looking at, whether it's infectious disease or chronic disease. I think part of also the problem that we have is that certain organizations, whether it be state, federal agencies, that are required to provide us the data that they are collecting, because we are a public health authority, do not recognize us as a public health authority. And I don't know how many times I can sit in a room and explain this to them, and they will say, we'll look into it, we'll check it, and they come back, and it just goes back and forth. And so it's important for us to relate to them that, we are authorities in collecting these data sets, or to assess these data sets. And I think part of the problem, like when we do data sharing agreements, is to point out to them, like, I will not sign a data sharing agreement that does not give me the ability to assess the data or analyze the data as I see that it should be analyzed. I do not necessarily will approve of the fact that they have to see my analyses before I publish a paper. It's important that they recognize that we are epidemiologists. We have, the same training. We are fully capable of doing this. And I think we do a better job at it because we really look at Indigenous values as the foundation to the work that we do. And so I think we look at things a little bit differently than say like states or federal government agencies look at the data or analyze the data. I think that sometimes, like, I give you an example of the state of Washington and the data that they just recently have published with regards to vaccination. They're showing data in a way that is misleading. And I think it's important for us to point those things out because ultimately it impacts resources that we received, and it impacts the programs that are being developed, and it also impacts the actual values of rates or proportions. I don't think we get the true value or understanding of the impact of COVID-19 on our population. So I'm going to stop there. Because I know we want to do some questioning, some questions and answers. But I just wanted to give you, this is what the work that we're doing, and really trying to hold states and CDC and any agency that's collecting information on this accountable to us, and accountable to to Indigenous people, and making sure that they are doing this correctly and they're presenting it correctly.
Thank you so much, Adrian. I think you raised some really important issues with regards to the data collection protocols and procedures that clearly are flawed and incomplete, and also just the lack of knowledge and understanding about the status of tribal epidemiology centers, even now, more than 10 years after the fact that there's been federal legislation confirming the public health authority of tribal epidemiology centers, which then, of course, have ramifications for the data that you see that are in your hands in terms of how you're able to gain access to the information that we can all use to make data-driven decisions, particularly around COVID-19 response and vaccination response. So I really appreciate all of the issues that you've raised and brought to the forefront today in our conversation. I think, we have about 20 minutes left, and just want to thank you both so much for your very important presentations today. We did have a couple of questions to kick us off. I think, it would be probably helpful at this point to actually just, Danielle, move to the questions from the audience. I know that, there have been a couple of issues that have been raised in the question or in the chat. And I think one thing, that is important to underscore are maybe some of the cultural issues that you all have seen, in terms of COVID-19 response, and perhaps the lack of cultural congruency between, what your efforts are doing, for example, at White Mountain Apache, Chairwoman Lee Gatewood, and maybe some of the folks that are wanting to help but who don't necessarily have that cultural grounded approach. And you talked a little bit about that, in your partnership with Johns Hopkins University. And I wonder if you could speak to that with regards to COVID-19 response, and if that's an issue or how that's working for your community. Oh, you're on mute, Chairwoman.
You mean in terms of how the partners have come in and started working some of the challenges that have posed in this response?
Yes, that would be great.
Well, we during COVID, we have had, unfortunately, not necessarily medical personnel, but different entities, different businesses who are wanting to take advantage of the tribe. For example, I carry this around with me wherever I go. That's just what I do. But there were people that were coming to tribal homes and just, trying to get our elders to go and buy something through tactics that made them feel like this will help you in whatever you're doing. So we really had to educate our people to ask questions. And here's who the tribe has gotten to help our people, and here's what they'll be wearing, those types of things. But as far as other partners, there were times where the limitations that we would put on some group, they didn't like that. They wanted the ability to just run with whatever they had. So when that happens, we would say, you know what, you really don't need to be here. And that only happened on 2 occasions. So with that, it was a struggle, but we emphasize that the work that we have, we collaborate, we work together, but it also takes the emphatic leadership to turn those agreements into productive outcomes. You have to breathe life into those agreements. We can't just have words on paper. We actually have to realize and really act upon what we said we would do, and we hold each other accountable to that. We're transparent to the people, and then just the bottom line is how we have a shared sense of responsibility. If everyone can have that, we have a shared sense of responsibility of what we are doing here in order to have a positive outcome of helping people, and we work together through that, we have less anxiety and tension amongst each other. And when we remove those individual group, I think one or two that really didn't have the mission and goal of what we were trying to do, we said, no, thank you. We are here to focus on our people, and we are here to help in this. And everyone had that shared sense of understanding and moving forward that really strengthened the anchor of what our mission was. And I believe that is a testament to the outcome of how we went through this pandemic. We're still in it, but it wasn't as devastating, as what it may have been had we not had that understanding from the very beginning.
Thank you so much, Chairwoman. Adrian, the Chairwoman underscored the need to follow through on the agreements that are put in place. And I think you kind of spoke to that when you were mentioning the vaccination data in Washington State. And I wonder if you have comments that you would like to add to that in terms of kind of there's the agreement and what's on the paper, and then there's the actual data that's available, and how that has worked in terms of the vaccination data that you've seen and had access to in Washington State.
Yeah, I right now I don't think I'm Washington State probably is I'm a thorn in their side right now, and I think here's the problem, I think, and I think that a lot of times what ends up happening is that state health departments, local health jurisdictions, federal agencies want us to accept whatever they say or they produce as this is the word, this is accurate, that this is the information that has been collected, and we need to take it because they say that's the information. And I think it's important for us to understand, this is where what we do at our agency and the efforts that I lead is that I have my staff always question that data. I want to know how they defined American Indian Alaskan Native. I want to know how, what their numerator denominators are. How do you come up with the values? I want to be able to replicate the information that they are providing. When I can't do that, I suspect those numbers. There's a huge suspect in the data that is being presented. And as a result of that, then I question the validity of that information. And I also then question the validity of the efforts that they are trying to put forward. And I'll give you an example. I've been for the longest time in meetings explaining to them the importance of them giving us the information on vaccinations. And I still haven't received the data from the Washington State on vaccination, but yet they're producing reports on vaccinations, right? I've asked to get access to that. And what they're doing is that they're putting data out there saying that, okay, within, the population of people that are being vaccinated, there is so many, like this percentage of American Indian Alaskan Natives are being vaccinated. And it's much higher than it is than if you look at white non-Hispanics. Well, yeah, it is if you look at it in the way that they do, but they're using a different denominator for that comparison. And so if you they're comparing apples to oranges, but if they could And when they do that, what they're showing is that only 60% of white non-Hispanics are being vaccinated in the state of Washington. But if you actually compare apples to apples, it really turns out that about 80% of people being vaccinated are white non-Hispanic. Now, part of that is that they have different priority groups that they are focusing in on. And my pushback to them is that, when you identify specific priority groups, what you are doing is alienating certain people of color groups, communities of color, because they don't necessarily fall into those priority groups. There's not a high proportion of them, right? And so what we see is, again, a disparity and inequity in the distribution of vaccinations. And so I think what's really hard is the fact that information is being provided, but it's not accurate. And I have to take the time, my staff has to take the time to pick it apart instead of working together in a collaborative way so that we can produce correct and accurate information. Now, we've been working on this relationship, and I'm hoping in the next month or so that we will have a good understanding of one another, and that we will be able to work on things. And I point Washington State out because we're here, we've been doing a lot of work with them, but this is also across the board with other states in the US that we have been working with as well. It's just been a real struggle to get that information. And yeah, they want us to sign a data sharing agreement, but I'm very hesitant when they propose restrictions on me on how to do my analyses or what I can report out. And I won't do that, so.
Thank you, Adrian. I know that some other issues, that folks have mentioned in the chat is the importance of Indigenous people doing the data analysis and data collection. And I wonder, Chairwoman Lee Gatewood, if you can speak to that in terms of the folks who on the White Mountain Apache side have the ability to review the analyses and perhaps, conduct some analyses and see, what that looks like and how, maybe the insights from tribal members or perhaps other folks on the White Mountain Apache team are shedding light on, some of the trends that you're seeing with COVID-19 in your community.
With the shared sense of responsibility that I mentioned earlier, that understanding, our tribal members do have the opportunity to share, to read the data that comes in real time. And what helps there is our White River Service Unit has an in-house lab, whereas before, when COVID first began, we used to send all of our tests to Phoenix. We'd have to wait for 5 days for the results to come back. And remember how I had mentioned how we started contact tracing at the beginning. All of that common ground of coming together and sharing the information amongst the health professionals, having our tribal members also at the top. Our CHR was very instrumental, our community health representatives. They're all tribal members of our tribe. And what they did was they went with our doctors and our nurses wherever to the community. And Johns Hopkins, who is epidemiologist, did the reports, met with our tribal health board and the top two director and assistant director, if you will, of our local office, are tribal members who have masters in public health, and they are trusted individuals in the community. They would interpret the data, and whenever discussions came to the tribal council level, they were the top two that came and with their epidemiologist, with the data that they gave to us and said, tribal council, here's what we have. They would interpret. They would also because they've been members of the community who resided here since they were born, they knew exactly how things would affect our tribal members. And then having that shared responsibility of going out into the community and really taking stewardship and having that trust responsibility of, you have to maintain the trust of the people and constantly updating. And in my role as chairwoman, I also serve as public information officer for my tribe. So when I go on the radio during COVID-19, I have to interpret whatever information I get in my own language for the listeners out there. And my goal has always been, if I can explain to a tribal elder, for them to accept the information and say, okay, yes, I understand, that was good. And allowing them to ask questions. It is so important to ask questions when you don't know, just like Adrian said, to have that openness. And I would get on the phone with our non-reservation communities, because we do have a hospital there where some of our tribal members would go for treatment. And because of the stigma of your COVID, you must quarantine, there was that stigma, and then you were kind of treated as like an outcast. So some of our tribal members went to this hospital, and then we were like, how can we get that data? We need to work together. So that's where we went to their board and said, we have an obligation to protect our people. We're in a public health crisis. We're in a pandemic. We live in this community of our Indian reservation, and we want to help in this contact tracing. Knowing the fact that none of us had ever been in a pandemic, they went ahead and said, here's how we can do that. And I honestly thought that there would be a lot of pushback, but there wasn't, because of the fact that they also had a responsibility to protect the public health of all of the citizens that live in this mountain community. So that helped, but that doesn't always exist everywhere else. We have our tribal members that live in metropolitan areas, other states, wherever they're getting treated. Data is so important in order to assess and analyze, but our tribal members who are boots on the ground, who know our people, who have been through the crisis and the trauma, are the ones that we rely on. And they've been very tremendous in maintaining that. Here you have your health officials who are not from our culture coming to help. And we have our tribal council, our leadership, and then the tribal members who are part of the health community. We kind of are like the middle person to the health officials. That's why we stress trust, and that they learn about our culture and community, and allowing the data. We just send it out every day. Here's where we are. Here's how many we tested. All of that, so that the people can be like, okay, they're being upfront with me. They're communicating with me. And allowing them to ask questions, allowing them to interpret. And wherever I go, people will have some question about COVID-19. And that requires me as a leader to be up to date on what's going on, what's out there, and also advocating for the vaccine, what have you. It's a constant, almost a constant 24/7. And even on my social media, I get thousands of inquiries on my messenger about the misperception of COVID. And I just spend time answering, because I want them to feel like she took the time to answer my question. She's telling me where to go. And as you keep doing that, people are like, okay, I can do this. And it's been a tremendous challenge. But as long as you have your tribal members taking an active role in the research and the data collection, and how that data is treated, And then tribal leadership, making sure that we continue to own that data and that the health officials understand. It'll be more unified and a greater positive outcome.
Thank you so much to you both. I really appreciate your time, and I know you're both very busy, and I want to be respectful of your time. We do have a brief poll. If you could give us some feedback before you leave, that would be really helpful to us. And I want to call your attention to Dr. Jamie Ritchie, who is also on the call, who has made this possible, and her team at the Intertribal Council of Arizona. So thank you, Dr. Ritchie. Thank you, Esther. And I just want to, thank you all for joining us today. I hope that this was a really helpful discussion. I know I learned a lot, and I really appreciate, your time and all the really critical points that you've raised today. And I know that we could, go on for some time. I think there's a lot to unpack here, and I hope, that we have the opportunity to do that at some point in the future. So thank you so much again, and everyone, hope you all take care during this time. And if you have any questions, please do let us know. And also just wanted to mention Dr. Ritchie provided a link to one of the articles that Adrian mentioned in his presentation in the chat. And so if you're interested in following up, you can certainly access it there. And we will also put that on our website. There will be a recording, as I mentioned earlier, of this session on the indigenousphi.org website. And there will be links with the Intertribal Council of Arizona website, so that if you missed a portion of the discussion today, you can definitely access it. So thank you all so much, and have a great weekend.
Thank you. Thank you for having us.